Welcome everybody to the USC Division of Breast, Endocrine, and Soft Tissue Surgery Ambassadors webinar. We put this together. We typically do it at the beautiful Langham Hotel in Pasadena. Unfortunately, at this time, we are unable to do that for obvious reasons. So we do appreciate everybody being here, being online. If you're like me and you're on Zoom a lot during the day, some of our Zoom calls are fantastic. Other ones, maybe not so much, but we hope that this is one of the Zoom events that you find helpful and meaningful and bring something of value to your life. We're really, really happy that you could be here with us. I'm going to start with a slideshow of my own with some historical perspective. And that's where I'm obviously not the clinician. So whenever I do a show like this, I say, hey, surgeons, you step in and correct me if I'm wrong anywhere. Without any further ado, because I don't want to take up all of the time, I'm going to walk through slides and talk about why we're here. Number one, we want to educate. So talk to our group about that academic medicine experience. It's different than a community. It's different than maybe your hometown type of medicine. And it's incredible. We'll go through that. And then second, we're going to examine advances in surgery and surgical oncology. We've got the right people here to talk about it. And I'm going to just set the tone for where we started. And then we're going to explore ideas and some opportunities for philanthropic impact and what that means. You know, it's always helpful when people, they either are say, I want to make an impact, I want to make a gift, or sometimes it's even just, if you tell your story, we'll give you ways to do that as well. So academic medicine, some of the best and brightest choose academic medicine for some really specific reasons. And that's all about research. So how to conduct research, and they want to improve patient care and address those community needs. The second is to train the next generation of physicians, surgeons, and scientists. There's a lot of crossover between surgery and science. And that's, it really is mind blowing because it hasn't always been like that. And then three, to provide the high level of quality patient care, especially in those local communities. I know that Keck Medicine serves a lot of the community around us and even beyond. Dr. Will Sang, who's on the call with us today, will talk about where some of his patients come from in his particular specialty. What you're going to find at an academic medical school are those who dedicate themselves to really specific surgical specialties. Our entire department of surgery is set up in such a way that you've got cardiac surgeons, you've got thoracic surgeons, you've got plastic surgeons, you've got surgical oncologists. We do this for a reason where everybody is highly specialized in their particular area. So you won't see any of our physicians doing a gallbladder surgery at 8 a.m. and then a breast cancer surgery at noon. These physicians here are sometimes the last vestiges of hope for people that have some really inexplicable and complicated medical problems. We do a lot of clinical trials. We've got high volume, and with high volume comes high quality and high collaboration. I want to show you a picture here, just again, for the last hope. There was a patient who came to us and he shared his story. And a lot of his friends and other physicians were saying, maybe you just need to lose weight. Maybe that's a beer belly. But actually, and I'll have Will talk about this, Dr. Sang, he was a patient that had a sarcoma. So a 77-pound sarcoma at that. That's the weight of a 10-year-old boy. So just to put that in perspective of academic medicine is the place where you can be treated for something like this. There's a lot of reasons that surgical expertise and volume collaboration matter. I don't need to read every single bullet point here, but there are just those higher levels of training, fellowship, which I'll have Dr. Tarano talk a little bit about, they really do impact those surgical outcomes. The volume, the more that you do, the better that you get. And that's the same as when you're learning to drive a car, right? That's real nerve-wracking in the beginning, but you sort of get that muscle memory. And the more surgeries that you do, the more cases that you see, the better you are at it. We've got a really high range of specialists here. Things are staffed for particular reasons, and we'll see that our outcomes and patient satisfaction really are reflective of that. This is one of my favorite slides because what we've got here is what I'd like to call a barber surgeon. So this is an 18th century barber surgeon where you could literally be asking someone, are you here for a trim or an amputation? So it just goes to show that we've come a long, long way in medicine. This picture next to it is one of the first images of what a mastectomy would have been like for patients around that same time frame. Secondarily here, again, just more of the surgical tools that were used for breast cancer treatment. It's near horrifying that this is actually part of the truth and the knowledge that was surgery at that time. Here's a picture of a tumor in 1817. Now, when I shared these slides with Dr. Tarando, she says, rest assured, there is not that much blood in surgery. But back then, this is even before anesthesia, which didn't come out until 1846. One of the last slides I've got here just for a historic perspective is here's a surgical theater in the early 1900s in London. There's actually used to be a theater like this at LA County, the old county hospital. And you might notice here that they're not wearing masks, they're not wearing gloves. There's a ton of people in there and it doesn't look safe at all. But it's the evolution of how did we used to learn, what do we do today, and how does it get better and better? In the 20s, which I find this is fascinating, you could be declared a surgeon if you had practiced on cadavers and animals for only 6 months. And if you ask any of our experts here today whether or not they've practiced more or less than 6 months, I think you will be surprised by what it takes today. In 1882, William Halsted performed the first radical mastectomy, and that was actually the standard of care until around the 1970s, to be more specific. We've got a group of experts here as our panelists. We've got Dr. Alicia Tarando, who's the division chief of this breast endocrine and soft tissue surgery, and she's going to talk about how those things all fit together. Dr. Ozzy Carr, Dr. Maria Nelson, and Dr. Will Sang. I would also like to say, and just quickly here, that not only do they practice surgery, but they've got a ton of publications. So they're doing surgery, they're writing papers, they're reviewing textbooks. This is only a small fraction of what it is that they do. So I don't necessarily expect that you'll sit and read these out of hundreds and hundreds. But I did want to show just the volume of not only is it surgery, not only is it teaching, but it's also contributing to the advances in medicine. So with that, Dr. Tarando, do you want to introduce yourself and your team?
Yes, absolutely. Thanks, Angie. So my name is Alicia Tarando, and as far as background, I grew up on the East Coast, and I went to medical school at the Medical College of Pennsylvania in Philadelphia, and it actually used to be called Women's Medical. It was actually the first medical school that admitted women. So after that, I did my general surgery residency at the University of Michigan. And then I decided I wanted to focus on cancer surgery. So I went on to do a fellowship in surgical oncology at the John Wayne Cancer Institute, which is located in Santa Monica. So all told, with research and fellowship and general surgery, this was 11 years of training after medical school. So after finishing my training, I spent 8 years at The Ohio State University. I was an assistant professor, and I focused on treating breast cancer, melanoma, and other skin and soft tissue tumors. I then came to USC in the summer of 2018, and I continue to focus on these same diseases. And I had the opportunity to join a really excellent team of surgeons. So with me, I have Dr. Nelson, Dr. Carr, and Dr. Sang, and I'll let them each introduce themselves. Dr. Nelson, would you care to start?
Sure, thank you, Alicia. So I'm Dr. Maria Nelson. I'm a breast surgeon here at USC. I grew up in the Midwest in South Dakota. Most people I run into say, South Dakota? I've never met someone from South Dakota. So I never dreamed big. I thought that I would end up in South Dakota. And after medical school there, I landed in Santa Barbara, which I thought I had won the lottery for general surgery training. Loved it. I didn't see much of Santa Barbara. I was inside the hospital most of the time, but it was wonderful. And then I discovered that my love was breast surgery. So I went on to fellowship at Cedars. That's what brought me to LA. And my husband also works at USC, which kept us in LA. And then I got a job at USC. I love doing breast surgery. My mantra and the mantra of my group is breast is best. So I have indoctrinated them with the Kool-Aid, but I absolutely love it.
Great. Ozzy, did you want to go next?
Hi, my name is Dr. Ozzy Carr. I also grew up on the East Coast in Maryland, and I did my medical school at Columbia University in New York and my surgical residency at Albert Einstein Montefiore in New York. After my residency, my interest was in endocrine surgery. So I spent a year at the Medical College of Wisconsin doing a fellowship in endocrine surgery, which focuses on thyroid, parathyroid, and adrenal disorders. I stayed on to practice in Wisconsin for several years, and I decided that I wanted to expand my practice to also include surgical treatment for breast disease. So I was accepted here at USC to do a one-year fellowship in breast surgical oncology 2 years ago. And I was happy and delighted that they asked me to stay on to join the faculty. And so now my practice focuses on breast surgery as well as thyroid and parathyroid surgery.
Great. And last but not least, Dr. Sang, did you want to introduce yourself?
Yeah, of course. Well, very glad to be here. My name is William Sang. I'm a surgical oncologist, and my focus is on soft tissue sarcoma. My background, I actually grew up here in LA, from Arcadia originally. So I remember driving by USC and just being part of the LA scene. And I went to medical school in Chicago at Northwestern, and then did my general surgery training at UCSF, and decided I wanted to do surgical oncology. And so I did additional training fellowship in surgical oncology at MD Anderson Cancer Center in Houston. It was there that I also did subspecialty training in soft tissue sarcoma. So I don't have a specific certificate for this. There is no certificate for it, but it's something that I got additional training for, soft tissue sarcoma. And I've been at USC now for about 7 years, focusing on this disease. So glad to be here.
Thank you, everybody. It really. So I guess it's a little bit more than 6 months based on what you shared. So Dr. Tarando, I'm going to start with you, just based on what you just shared with us. You mentioned that you and actually the rest of the group here, did fellowship in surgical oncology. Can you tell us what the difference is between a general surgeon and then a surgical oncologist?
Sure. So after medical school, 4 years of medical school, everyone here, we completed a residency program in general surgery. So we're all broadly trained in all aspects of general surgery. So that includes breast and thyroid and colons and livers and appendixes and things like that. But then each of us spent an additional 1 to 3 years getting additional subspecialty training, where we learned both the surgical and the non-surgical aspects of treating cancer specifically. So while a general surgeon will simply separate a patient from their tumor, we are actually primarily oncologists. And it's just that our treatment modality happens to be surgery. So from that perspective, we come up with a treatment plan that considers how surgery fits in with the other treatment modalities like chemo and radiation. And so I'll give you an example. There are certain types of breast cancer that should be treated upfront with chemo. And this is to provide the patient with their best outcome and the chance to minimize the amount of surgical intervention. So we might have a big tumor that would require a mastectomy, but if we give them chemo up front, that tumor can shrink so they can get a lumpectomy. Sometimes it goes completely away. Also for axillary surgery, so the lymph nodes, we used to take lymph nodes out for everybody, but now, especially after chemotherapy, sometimes we don't even have to do that anymore. So if a general surgeon takes that patient straight to surgery, they may end up doing that patient a disservice in the end because they deprive them of the opportunities to optimize their overall outcome.
Wow. So there's more and more and more. I've never actually felt worse about myself than when I'm with this particular group of geniuses. But each of you, there's always the opportunity to go to private practice and then go to academic surgery. And one of the first slides I showed is why some people have made those choices. Do any one of you on the panel want to describe why you chose academic surgery over private practice? Because I can call on.
Sure. I can go ahead.
Yes.
So I think one of the main differences in practicing at an academic center is the collaboration that occurs among the other services. Working in the field in oncology, where it's not just, as Dr. Toronto mentioned, it's not just the surgeon that's part of the treatment plan. It may be the chemotherapy that the patient requires, the radiation patient requires. It's multiple different services. And we work closely with those other services at an academic center in a way that you probably would not be able to in private practice. We have weekly tumor boards where we discuss all our patients, come to a consensus on what kind of treatment that they should be receiving. And even our clinics are in often at the same time, where I have a medical oncologist sitting next to me as I'm seeing my breast cancer patients, where I can ask them a simple question, oh, what do you think about this? Or they can ask me, and do you want to come see this patient? And we really can work very closely together.
So I understand that that gets me thinking that USC, the breast center, does things a little bit different than maybe some other places. And not that long ago, we launched a multidisciplinary, a truly multidisciplinary center. Either Dr. Tarando or Dr. Nelson, do you want to talk about what that is? What does that mean? You know, as kind of the lay person, isn't that what everybody does? What makes it different?
I'm happy to interject, and then maybe Alicia, if I missed something, you can chime in. So the multidisciplinary approach, we have actually kind of two levels of multidisciplinary. We meet every Monday, and we discuss all of our surgical cancer patients as a team. We meet with our pathologist who brings the actual physical slides of the diagnosis. We meet with our radiologist who show all the pictures. We have our medical oncologists, the radiation doctors, the surgeons, the geneticists. Everyone in the team meets every week to discuss our cases that we're taking care of. But there's even another element that we launched in the last couple of years where women with a new breast cancer diagnosis can come to clinic. Every Monday we have this clinic, and they get to meet the whole team of doctors and ancillary support. So this means 3 to 5 physicians can see a brand new cancer patient. The patient gets to stay in the room and the doctors rotate through one by one. We all have discussed the case, identified the plan of care. In the afternoon, if they wish to see the rest of the team, they can meet the geneticist, the occupational or physical therapist, a nutritionist, a social worker. It's kind of like a la carte shopping on Amazon. You just click what you want and they all come and rotate through. And then there's a summary at the end of what the care plan is. I think that's just truly exceptional. As a patient with a new diagnosis, if I had to experience this would be the kind of care I'd want, to know the whole plan, have it all articulated, meet the team, and know that they're all communicating together. And then one final thing, just to kind of overlay with what Ozzy was saying, our breast center is integrated with our breast imaging center. So when patients come to us, they can have the imaging the same day, or if we feel any changes in the breast, we can stop and say, I want to get this ultrasounded, or I want to get a mammogram, and we can have them go seamlessly right over to breast imaging in their gown and come right back to us with that imaging, which I think is, wonderful.
What kind of time do you think that saves somebody? My own mom, who doesn't live in California, lives in another state. She was diagnosed with breast cancer maybe 3-4 years ago, and she's cancer-free now. But I remember when she was first diagnosed, just that fear of, where do I go? Is this doctor talking to this one? And this is really scary for her and the whole family. So to imagine being able to do that all at once is it's highly unusual and really special.
Yeah, we're hoping we're saving, weeks of potential back and forth between doctors' offices.
Yeah, man. Dr. Turando, I've got something for you, and Dr. Sang, I've got a ton of questions for you, but I want to make sure that I cover everything here. So this is a unique group that you've got here. So we're talking about breast cancer, endocrine, and soft tissue surgery. How are all of those related?
Sure. So the commonality is that, whether it's breast cancer, sarcoma, melanoma, these are all solid tumors, and they are all treated in some way with surgery. And this is what we all specialized in when we went and did our fellowship training. So while the tumors are managed differently based on the tumor type, ultimately the surgical principles are the same. And also, if you think about specifically breast and melanoma, those are the 2 disease types that I focus on, but they really go well together because they both behave in a similar way. So they spread through the lymphatic system. So the way that we handle these from a surgical standpoint is very, very similar. And finally, we're specialists in cancer surgery. So it's really more about treating the cancer with surgery rather than focusing, on just a particular organ system and all the diseases, benign and malignant, that might occur within that system.
Really helpful. That gives me a better idea, and hopefully some of our participants a better understanding of how everything is related here. So the format for the rest of asking these questions, I always have what I want the questions to be, and then we go off into our own worlds, which I think is fantastic. So if I lay this out and we don't stick to it, my apologies in advance. But I'm going to ask first questions, a couple of them about breast cancer, And then we're going to switch to Dr. Sang, and then we'll switch to Dr. Carr to give each of you an opportunity to talk about what it is you do and how you do it different. So Dr. Nelson, this is for you. I've heard that the guidelines for mammography and screening have changed recently. What can you tell me about that? And what are you and the doctors at USC recommending?
Yeah, very good question. And patients can get confused by it because the American Cancer Society and the U.S. Task Force a few years back were altering some of the common knowledge that we had about starting mammogram. They were suggesting instead of starting at age 40, starting a bit later, instead of going yearly, maybe going every 2 years, and then suggesting that there might be an end date. All of that is confusing to patients. Much of that was motivated by trying to decrease cost and decrease callbacks and false biopsies. Our guidelines from the American Society of Breast Surgeons and the American College of Radiologists, who dictate the mammogram reading, still adhere to the good tried and true: start at age 40, continue yearly until your health precludes you from having additional imaging or wanting to take care of something found in the breast. So that's how I would guide my patients. Now, sometimes patients have really strong family history or genetics that would need to elevate their type of surveillance or start them a bit early. So that's when you want to have a conversation with your doctor to figure that out. But I would just keep it simple and continue every year and start at 40.
Really helpful. And thank you for sharing that. I'm going to ask now that you walk us through just the basic mammogram. And I know that there's a couple of slides here that might be helpful to get people to visualize what that is. My understanding is that in the community, there are still the 2D mammography, and then there's 3D, and it can really be mind-boggling to know as a patient, what should I be looking for and why should I do that? So let me open up what you shared with me. Can you see that okay?
Yes. Yeah.
Okay.
So as you alluded to, there's a couple different forms of mammography out there. Both forms are digital. What we're talking about in terms of two-dimensional mammography has been the classic mammography for the last several years, and you're getting compressed in a head to tail position, so head to waist. As you can see here, the circle indicates the breast getting squeezed from the top down, and then usually there's a second view where women will have to kind of bring their shoulder in, and that's more of a lateral view. This has been replaced with 3D technology, and 3D is a series of pictures that are each a millimeter slice through the breast. So if you've had a 3D mammography, what you'll notice is that the arc of the mammogram, rather than being static and situated above the breast, it'll create a sunrise, sunset. And as it's going across in a beam-like form, it's taking a series of 1 millimeter pictures through the breast. And this is then put together, and an animation or a short video is created with all of those pictures stacked together. The advantage of this is that it can identify smaller cancers, decrease callbacks, so fewer coming back for uncertain results. And it's exceptionally good for dense breast tissue. And dense breast tissue simply means that there's more glandular tissue, less fat. And it's a finding that we use based on the mammogram. So some people will say they feel dense, but it's actually a description of how the mammogram looks. So this is giving you another picture side by side. As you can see, the mammogram looks black, white, and gray. You can see here the skin envelope on the outside, and then underneath the skin envelope, you see a white area, which is the glandular tissue, and the fatty area is the black. On the two-dimensional, it looks like that white glandular tissue is pretty uniform, but it doesn't seem to illustrate any change. When you look at the 3D and where the arrow is, you can see that that mass that looks almost spiculated or star-like or crab-like, you can see how it's much more noticeable with the 3D, and it's almost camouflaged with the 2D. So that's how it can help identify. Here's another cartoon illustration illustrating how the 2D gives you like the silhouette of the image, whereas the 3D is giving you that further detail of what's happening inside. And then another illustration or image is, this seems kind of silly, but it's a good illustration of a cupcake. So you can see that this is a carrot cupcake with frosting on top. And I think this is easy for patients to understand. If you were to smash a book on top of that cupcake, that's your equivalent of your 2D. And patients might feel like they're getting, slammed with a book when they're getting their mammogram. And then on the 3D, you see that if you were to slice that cupcake like a bread loaf and lay those slices out, now you start to appreciate exactly where the frosting is, where the cake begins, and all the little pieces of carrot. That's the level of detail you're getting with the 3D. So it's a better quality image. And I think what you're going to be finding is that the centers are all going to have 3D. USC was the first to have 3D in Los Angeles. All of our centers have 3D. It's the best technology.
I appreciate you sharing that with us. I do love the cupcake picture because in terms of looks and feel, it is seems very similar.
Yeah.
Want to talk right now real quick about soft tissue sarcoma and then also insert this idea to our viewers there is that be writing down or thinking about questions that you have to expand on, if it's breast cancer care or sarcoma, or when we get to thyroid to talk about that, because we're covering a lot of bases today. And I want to make sure that I get to Dr. Sang's soft tissue sarcoma. So I don't want to overlook your specialty. I believe that it's probably only studied in academic medicine because that's where these rare cancers are treated. But what can you tell us about what it is that you do? And there's a couple of slides here that might help walk through the process. So since I'm controlling the slides, you tell me how to move through it.
Sure. Yeah. So just as Angie brought up, the soft tissue sarcoma, it's a very rare cancer. It makes up only 1% of all cancers in adults. And I kind of skipped ahead a little bit. But that accounts for about 12,000 to probably about 15,000 cases per year. And I think what this slide kind of illustrates is that besides being rare, it also it can occur anywhere in the body. So you can see pictures here of a soft tissue sarcoma in the thigh. That's in that upper picture. And then there's another type of sarcoma, soft tissue sarcoma, that's occurring in the clavicle area. So it can be anywhere in the body. It's not shown here, but it could also be in the abdomen. One of the pictures that you showed earlier, exactly, that's another location. That particular part of the body is called the retroperitoneum. I know it's a little bit of a mouthful, but what that really means is it means the back of the abdomen. It's where the kidneys are, it's where the great vessels are. And these tumors in the back of the abdomen, the retroperitoneum, can get to massive size. Now, this is a little bit on the extreme side, but they do typically, these retroperitoneal sarcomas can be up to 10 to 20 pounds or more. And it's because they start in the back of the abdomen, they can grow over time. Into large tumors. And so so soft tissue sarcoma, I think, is challenging for non-specialists to treat just because of the variety of body locations. So we have to treat patients with sarcomas in the extremities, in the trunk, in the abdomen, in the back of the abdomen. And then on top of that, there's also many different subtypes. So one of the things that's not captured in these slides I'll just bring up briefly is the fact that within that 1% of all cancers, sarcoma, there's also many different subtypes, and they all have different behaviors. So putting it all together, it becomes very challenging for somebody who doesn't see this on a regular basis. So that's the advantage of our sarcoma program at USC, is that we do see this on a regular basis. And when I say regular, that actually means daily basis. This is all that I treat. This is all that the medical oncologist, the radiation oncologist, the other members of our multidisciplinary team for sarcoma, we see this on a regular basis. So that's kind of sarcoma in a nutshell there for you.
Yeah, that's a lot to take in just a Friday afternoon. But I appreciate you sharing that, because, you know, one of the questions that people might have is, yes, it's rare, we understand that, but at what point do people start, you know, what's a warning sign besides the actual, you know, wow, maybe I've got a lump, or maybe I've got something, I'm feeling bloated. I don't know. I mean, are you tired? Is it, what's the diagnosis usually like, the pathway, just out of curiosity?
Yeah. Well, it's there's not a straightforward answer to that, actually. And sometimes it can be very subtle. Sometimes these tumors, sarcomas, can be picked up on CT scans or X-rays that are done for other purposes. So that means that the patient may not have any symptoms that are specific to the sarcoma that they have, that they're diagnosed with. And in other patients, the symptoms can be very non-specific. They can be very vague. It can just be, for example, in the abdomen, it can just be fullness on one side of the abdomen that's been there for even several years, that has slowly been growing. So it's not necessarily symptoms like pain or anything alarming. It's just, it can be very non-specific, and that's why. So
basically what you're saying is that if you are a hypochondriac, you're probably going to go home and do some research on this tonight, because I'm sure that's going to be me. Thank you for sharing. And this is, it's really incredible work that you do. And you see patients from all over the world, right?
I do. Yes. We get patients from all over the country, all over the world. With our telemedicine capabilities, we're also able to expand that even more recently. And so it's a rare disease, but we do have patients that seek their care here at USC.
I appreciate that. So this brings me to Dr. Carr. You know, historically, we've done a pretty good job of keeping people in the know about breast cancer awareness and conditions. And then we come to thyroid, which is a little bit of a mystery to everybody. What can you tell me about the thyroid, and what's common and maybe what's not common? And you have a couple of, I think, really helpful slides here as well.
So the thyroid is a gland in the lower neck that sits in front of your trachea or your windpipe, which you can see there behind the thyroid, and to the sides. And it produces hormone that really has effects in all cells of your body. I mean, a lot of people think of thyroid problems causing weight gain and or potentially weight loss. A lot of those problems, if you have them, it's something to bring up with a primary care physician to regularly check your thyroid hormone, especially in women. As we get older, it is more common for women to have lower thyroid function and to need thyroid hormone replacement. But that's generally not a surgical problem. The problems that I focus on would be, we can stay just on, are thyroid nodules that may potentially be related to cancer. So thyroid nodules are very common. They can be present in greater than 60% of the population. And sometimes they can be something that you feel or see in the mirror, or a physician sees or feels, or a friend notices, what's that lump in your neck? I didn't see that before. And the simplest test to get, if that occurs, is a thyroid ultrasound, which can give us the characteristics and see if there is an actual nodule within the thyroid. And most of these nodules will, again, be benign, not cancerous. Really only about 5% are cancerous, but we can't know that for sure without doing a biopsy. Biopsies are done by generally by radiologists or by surgeons based on characteristics of the nodule. And there's actually national guidelines on what should be biopsied, and those were partially developed by USC radiologists. So we have experts in the field here at USC who focus on that.
So what would I, besides just feeling or seeing a lump, is there anything else that I might need to be aware of if it was a nodule?
So if you feel or see a lump and you get you or your doctor sees one, usually we do recommend that ultrasound. It's not something that you should be constantly checking or looking for. It's usually more noticeable than that. But if you notice something of that sort, or if you start noticing voice changes, your voice is starting to become more raspy or hoarse. If you're having difficulty swallowing and you're feeling like food gets stuck in your throat more, you feel more pressure in your neck when you're lying flat to sleep, those all could be things that would lead you to get an ultrasound. An ultrasound's very easy, not invasive test. And if a biopsy is performed, again, most of those would be not cancerous. But unfortunately, about 20 to 40% of biopsies may give us an indeterminate result, meaning that we cannot tell whether it is a cancer or something that is not a cancer. And in the past, when that occurred, we would really, our only option was to recommend surgery to remove either half or all of the thyroid. But newer testing that's been developing over the last 10 years, this is molecular testing of the actual biopsy that's done, has given us more information so that now we can avoid maybe 30 to 50% of these surgeries that we are actually unnecessary with that molecular testing. And that's something that we offer to patients who have their biopsies done here at USC.
So it sounds like between the work that you're doing for endocrine, well, thyroid in this particular case, and the advances in breast cancer care, that really you guys are working yourself out of a surgical job.
Yeah, I mean, really want to changes.
Which is not necessarily bad. That's, I mean, there it is that's the best kind of patient care. I have another question for you about hyperparathyroidism. What can you tell us about that?
So that's really an area that's potentially under-recognized. So your parathyroids are small little glands that sit around your thyroid. So your thyroid is already small. Parathyroids are, a normal one is about the size of a grain of rice or a pea. And those control your body's calcium levels. And some of you, if you get your lab results, you may notice, oh, my calcium is high. And a lot of physicians may not actually do additional workup to take a look at that, but longstanding abnormal calcium levels can cause problems in your bones, weakening of your bones, the osteoporosis. It can cause kidney stones. It can cause muscle and joint aches and pains. Even can cause like fatigue, depression, memory problems. And so if your calcium is noted to be high, there should be additional investigation to take a look at whether that's related to an elevated parathyroid hormone, which is just an additional laboratory test that your primary care physician can do. And if they do find an elevated parathyroid hormone, you should be referred to an endocrinologist or an endocrine surgeon who can help determine whether this is something that should be treated surgically.
So I just want to switch to some advances in medicine. We talked about that. I talked about that from, the barber surgeon to now what some of you working your way out of surgery, which is insanely incredible. What do you think are the biggest game changers or changes in your particular area? Dr. Tarando, do you want to answer that?
Sure. I think both for what I do for breast cancer and for melanoma, there have been some really rapid changes as far as the kind of drugs that we have for those diseases. And basically, they work so well in certain situations that they can actually make the tumors go completely away and either minimize the amount of surgery that a patient needs, or sometimes they don't end up needing surgery at all. There are also some surgical advances. So for example, for breast cancer, back in Halstead's day, they were doing these radical mastectomies and taking not only the breast, but the skin and the muscle and all of the lymph nodes. But now we've gotten into, okay, we save the breast, and then okay, well, maybe we can save some of the skin and the muscle and some of the lymph nodes. But now we've even gotten to the point where we can do a mastectomy and completely spare the skin envelope of the breast, including the nipple. And that used to be anathema because it's you have to remove the nipple. But the only reason we were doing it is because we were always doing it. And so we realized that actually, after we studied it, that we don't need to. So I think for both of those reasons, I think we're just able to do a lot better for our patients, for their survival and also for their aesthetic and just, personal quality of life outcome.
Dr. Seng, is there anything that you've seen in your studies, or where's the research leading you right now?
Yeah, well, I think analogous to what Dr. Tarando just described, we are refining the way we approach sarcoma from a surgical standpoint. And one particular example is that for extremity sarcomas, years ago, maybe 20 years ago, amputation used to be the standard of care, just like mastectomy years before would have been standard of care for breast cancer. If a patient had sarcoma, then we would have just done the amputation. Now that's completely changed, such that limb salvage is the standard of care. And that limb salvage includes good oncologic operation. So that means a good cancer operation, basically, and combining it with other treatment modalities like radiation. I think and that's for extremity sarcomas. For the big tumors in the back of the abdomen that we talked about earlier, retroperitoneal sarcoma, that's still kind of in evolution. But at least in the last few years, we've had a lot of collaborations with other sarcoma centers around the world to try to develop the best management strategies for retroperitoneal sarcoma, for just all sarcomas, but specifically for retroperitoneal sarcoma. And then the other thing that I alluded to earlier was the recognition that there's many different subtypes and that they're all very unique. So there's a lot of research going into that, figuring out what are some of the molecules that drive this particular sarcoma versus another sarcoma, and then what kind of drug targets can we use to, or what kind of targets can we use, and what kind of drugs do we have specific for that type of sarcoma. And sometimes that actually results in almost cure or dramatic responses, just like what Dr. Tarando was referring to in breast cancer. In sarcoma, there are subtypes where we have targets and we have good drugs for them, that it's almost like a miracle when we are able to identify it.
So again, based on everything that you all have shared, I can hardly believe that you have time to do all the things that you're doing. I mean, between we're talking about surgery and being in clinic, and I know that this group in particular is really, really treats their patients with an individualized, it's a really personal thing for people, and I really love that about this group of surgeons here. How do you make it all work between that and research and fellowship training and educating people? What is there enough time in the day to do all that stuff? And if there was one resource that you could have, what would it be, and how might that make an impact? Dr. Toronto, I've heard you talk a little bit before about research coordinators. In fact, I hear that quite a bit. What do research coordinators do, and would that help free up some of your time to do the things that you're really passionate about?
Yeah, so I was just going to editorialize and just say that a lot of this is about prioritizing, and then I feel like I have multiple balls in the air and I'm just trying to keep the most important ones from hitting the floor, But I mean, to be serious though, when we're in clinic, and actually just in terms of the different things that I do, my priority is taking care of patients. And so when we're in a clinic, we also want to advance the field. But when we're in a clinic and we've got, 4 new breast cancer patients, and we have a follow-up patient who has a new problem, and then there are people waiting, and yet I have a patient who might be eligible for a clinical trial, I'm just running around. I'm doing the best I can to just take care of the patients, but I don't really have time to sit down and talk to this patient about a clinical trial and sign consent and all of those things. So, and to keep the data. When I was at Ohio State, actually, I had a trial that I had no support for. And so I figured, well, in order to, advance my academic career, I might as well just do it myself. And I was told, like, you better not do that. You're going to make one mistake and that'll be the end of your career. And I was like, well, I'm going to try and do it. So here I was, like, I was doing all these limb measurements, like every couple centimeters all the way up a leg, and writing them all. I had my nurse, like, writing them all down. And then, evenings, weekends, I'm putting everything into a spreadsheet. So having someone to help with that would, I think, I would be able to just get so much more done.
Yeah, I've heard that actually quite a lot. And this is always interesting when we get to the portion of our session when I personally start talking about, well, what can we do to help? What can we do? Because I will say that this group and all of the surgeons that I work with, just incredibly humble and, sometimes uncomfortable, saying we need to have this, because the mentality of this group is that we got it, we're going to do whatever it takes to get to that next stage. And it makes me think, I'm going to share my screen one more time. I think it's important to share this slide, because what people don't understand about the work that we do, that there is a decrease in federal funding, and that private philanthropy is what really, for lack of a better cliche, is what makes people go from that what's good to great. So the work that these guys are doing here, when you have private funding, if it's $75,000 a year to support a research coordinator, then what that allows our surgeons to do is to go off and explore other advances and move that science a little bit faster, move that advancement in medicine a little bit faster. And that's incredibly important. We actually, as a department, we self-fund to support our resident research stipend. So in a lot of our divisions and departments, we've got, while we're training residents, we will spend $100,000 to send them off to actually become that surgeon scientist. So people think, oh, $100,000, that's so much money. And there's a lot of different ways to slice and dice it. I mean, this is where Katie McCorkle, our development director, comes into comes into play here is that she helps people put together gifts that are meaningful for them and make sense for their legacy and their family, and then also make an impact here. So a gift of $25,000 a year or even $5,000 a year, that's really a nice, it's really a nice way to honor your physician and the work that they're doing here. So Katie, I know we've probably gone over some of our time here, but are there any questions from the group that
Yes.
might need to be answered?
I think there are. We do. We have a few here. One very important one is, are you offering telemedicine right now? Dr. Nelson,
Yes.
are you seeing patients?
We are offering telemedicine.
Can we still see you during the pandemic if we want? I think there's a lot of concern out there for people. They're hesitant about leaving during their homes during this period of time. How safe is it? And are you able to share a little bit about what it's like to go on campus and come to an appointment? What are we doing to protect our patients and ourselves?
Yes, it's safe. Masks are required. Temperature checks are happening at the door. Any breast imaging or procedures, we arrange for drive-through COVID testing within 72 hours of all procedures. So that's a bit of an adjustment where previously we were doing same day biopsies and not testing, but now we're testing everybody. We have different locations, so you can see us on the main campus, you can see us out in Verdugo or in Pasadena, and those facilities are also doing temperature checks, pre-screening. Like in Verdugo, they'll call when you're in the parking lot, and there's staggered entry of patients. There's increased cleaning of all the rooms, so there's a lot of thought and care going into making sure it's a safe experience.
So are you recommending then mammograms to be done during this time?
Absolutely. Absolutely.
Okay. Great.
I'm sorry, Katie.
No,
now, just one other question, just on top of that. Have any of you seen an increase in maybe the severity of a cancer because you didn't catch it earlier during COVID? Or what would be the recommendation if people say, you know what? Why don't I just wait? I don't think I want to come in. What's the word on the street?
Anecdotally, I will tell you during March to April, when there was a bigger effort to close everything down, but during that period, we had stopped doing screening and surveillance studies. And I was seeing more aggressive cancers that were palpable, meaning I could feel them. Some even had lymph node spread. And that might have been a combination of the COVID and then not being able to be screened right away. So I think cancers do happen. They don't worry about a pandemic. And so try to take every measure, safety measure possible to stick to your mammogram screening. And if you are a bit delayed because of COVID, you know, don't sweat it. Just try to get in and get your imaging updated.
Thank you. Dr. Carr, can I self-refer if I think I have a thyroid issue?
So I guess it depends on what you think your thyroid issue is. My focus is on surgical thyroid issues. If you're, so that would be more if you're feeling masses, lumps in your neck, swallowing difficulties. If your primary concern is that you're having problems with weight gain or weight loss, changes in your hair or skin, those would best be addressed by your primary care physician first, and then referred if needed.
Okay, great. Let's see, we have one more. This goes to Dr. Sang. How would you diagnose a soft tissue sarcoma? Based on the photos, my husband probably has one.
Yes, it's a common question I get. Ultimately, the diagnosis does depend on tissue biopsy. So to have a tissue, either usually from a needle biopsy, to say that this is a sarcoma. There are exceptions to that, and what I mean by that is sometimes at a sarcoma specialist center such as ours, our radiologists are able to look at a CT scan or an MRI and be able to kind of tell with a high level of accuracy that this is probably a sarcoma, even without that tissue diagnosis.
Oh, okay.
I would say, though, that if there's any suspicion, probably to have that evaluated by at least a physician to start off, a primary care physician, to go down the pathway of should we do imaging first, imaging then biopsy. We're always happy to evaluate anything that's suspicious for sarcoma and doesn't have the diagnosis yet.
I'm Angie Sally Crew, the Chief Strategy and Development Officer in the Department of Surgery. Now that an hour has passed and I didn't say who I was. Really appreciate you, all of the fabulous surgeons. Thank you for being here. Have a great, fantastic weekend.